A patient won't come to you saying, "Doctor, I have mesenteric ischemia." My point is that in this video you won't find the classic organ system-based presenting of information. In other words, instead of looking at appendicitis, peptic ulcer disease, Crohn's disease, and so on, we will focus on patients' complaints and patients' demographics. From an emergency medicine standpoint, your first priority is to make sure that the patient's life is not in danger, or to make sure that it is, and to take appropriate action. In reality, however, most patients will not die right in front of a doctor. Hence, your second task is to know the common causes of the disease. For every patient with appendicitis in your practice, there will be 15, 20, if not more patients with gastroenteritis, and both will have abdominal pain as their chief complaint. So remember the popular saying, common things are common. Your third task is to relieve patients' suffering, and it won't always be about treating the cause of the disease. You can make the patient's life better in many different ways, but I'd like to focus on 3 in particular. Cure the cause. For example, send a patient with cholecystitis to surgeons for cholecystectomy. Help symptomatically. For example, give intravenous saline to a patient with dehydration due to gastroenteritis. Provide answers. I especially want to mention this point. In my experience, a significant percentage of patients go to the doctor just to figure out what's going on with them. Why do I get bloated stomach after every breakfast? Why does it hurt to have sex? Will I ever be able to get rid of cancer? You must always be honest with your patients. As a doctor, you have your patients' trust, and they, sometimes in vain, think you know all the answers to all their questions. Even if you don't, share your ideas, explain statistics, just ask them what's on their minds and how you can help. I can't tell you what exactly causes bloating with more tests, but these symptoms are most common due to lactose or gluten intolerance and irritable bowel syndrome. Let's try a few different diets while you're waiting for test results and see if that helps. In order to answer this question, I need to know a little more about your problem. Please tell me more about exactly what bothers you during sex. And don't worry, lots of women face with these difficulties, and usually such problems are solvable. I can't tell you for sure in your particular case, but statistically it's unlikely to get rid of pancreatic cancer at this stage. However, that doesn't mean that I cannot help you. You and I can try different treatments to prolong your life and relieve your pain and nausea. Generally speaking, pain itself comes in many different forms. For convenience, let's break it down to a few basic types. Visceral pain. It originates from receptors in the wall of hollow organs and in the capsules of parenchymatous organs. Pain from such receptors is blunt and difficult to localize. Visceral pain from various abdominal organs is usually perceived in 3 anatomical locations: epigastrium, central abdomen, and lower abdomen. The reason for this is in the embryological development of organs and visceral pain receptors. Organs originating from foregut, such as stomach, pancreas, liver, and proximal part of the duodenum, produce pain in the epigastric region. Pain from midgut derivatives, middle and distal parts of the duodenum, small intestine, and proximal parts of the colon is felt around the umbilicus. And the posterior colon derivatives, the rest of the colon, hurt in the lower abdomen. Parietal pain. It is produced by the nerve endings of the peritoneum and projects at the level of dermatomes. This means that such pain is much easier to localize and usually is perceived as sharp or stabbing. Reflected pain. This is when the pain originates in one place and radiates to another. For example, with cholecystitis, the pain may radiate to the right shoulder. Specifically for the abdomen, spastic pain is also common, which is associated with the peristalsis of the intestines. With the onset of a peristaltic wave in the painful part of the intestine, there is a sharp pain that gradually subsides within 1 to 2 minutes. Pain burning. I mentioned this type because of our topic. Burning is extremely specific to urinary tract infections. For medical purposes, it is important to understand the different types of pain because it makes a big difference in your treatment plan. For example, a patient complaining of spastic abdominal pain who sits comfortably in a chair and plays phone is much less disturbing to me than a patient lying in fetal position with sweat on their forehead complaining of a localized sharp abdominal pain. In terms of physical exam, it is primarily important for us to be able to distinguish between sick and not sick patients. It is a basic skill for any physician, regardless of the complaint patients come to see you for. When differentiating between sick and non-sick, common sense come into play. How does the patient look? Are they lying unconscious, calmly talking to you, or anything in between? How does the skin look? Is there pallor, jaundice, cyanosis? Are there drops of sweat on the face? Is the patient shaking with chills? You should also always use the vital signs: heart rate, respiratory rate, blood pressure, temperature, saturation. Is the blood pressure dropping? Is there fever or tachycardia? Simple, cheap, fast, and you can already tell if your patient is septic. Speaking specifically about acute abdominal pain, we of course need to be able to diagnose acute abdomen, aka peritonitis. In addition to the classic stiff and painful abdomen and the symptoms of peritoneal irritation, extremely sensitive findings for peritonitis are sharp abdominal pain with coughing, sharp abdominal pain when tapping the heel of the straightened leg, especially good for pediatric patients. And of course, if you suspect a specific pathology, you should always use manures specific to that disease: Murphy's symptoms for cholecystitis, costovertebral tenderness for pyelonephritis, pain at the Mac-Burnett point for appendicitis, and so on. So, abdominal pain is a huge and very complex topic, and there is no way we can cover all pathologies associated with this complaint. So let's focus on the following: things that will kill them, and common things are common. In real practice, patients will rarely complain of isolated abdominal pain. Usually you will encounter combinations like abdominal pain and vomiting, abdominal pain and diarrhea, or abdominal pain and fever. This will allow you to narrow down the differential diagnosis. I thought long and hard about how to structure this video and decided to go with chief complaint and who is your patient. Let me explain. Abdominal pain in a 20-year-old girl suggests completely different pathology than the same complaint in a 70-year-old man with a bunch of comorbidities. Abdominal pain in a baby from birth to 3 months. Here you first need to understand that the pain is in the abdomen. Babies at a very young age cannot complain or even localize the pain. Most likely you will hear from a parent something like, "My son won't stop crying and his tummy is swollen," or "He's always screaming and he started vomiting today." The what's going to kill them category. Necrotizing enterocolitis. A catastrophic disease with a horrific 20 to 30% mortality rate. Incidence is about 7% in infants weighing 500 to 1500 grams. In other words, if your patient is a premature infant with any abdominal problems, always keep necrotizing enterocolitis in mind, especially if the patient is formula fed. The classic triad of complaints: refusal to eat, bloating, and bloody stools. Diagnosis is made with abdominal X-ray. The pathognomonic findings is intestinal pneumatosis, which is gas in the intestinal wall. Intestinal volvulus. The diagnosis is associated with intestinal malrotation, a congenital abnormality in which the intestine twists improperly around the superior mesenteric artery during intrauterine development. The classic complaints are vomiting, bilious emesis, abdominal bloating, and constipation. The diagnosis is made based on the GI X-ray with oral contrast, such as barium. The pathognomonic finding is a bird's beak, an artifact caused by abnormal bowel positioning. Strangulated hernia. Among infants, strangulation of indirect inguinal hernia is most common. Prematurely born boys are particularly susceptible. Diagnosis can be made clinically based on physical examination. If the hernia cannot be reduced, there is a high probability of necrosis of the pinched part of the intestine. Testicular torsion. It might not kill the patient, but it could kill a testicle. It is believed that if the testicle is not untwisted within 12 hours, it will have to be surgically removed because it will be non-viable anymore. Hence saying, time is testicle. All boys and young men with lower abdominal pain should raise suspicion for testicular torsion. Diagnosis is made on the basis of physical examination and testicular ultrasound with Doppler. Hirschsprung's disease. The pathophysiology of Hirschsprung disease lies in the congenital absence of an intramural nerve plexus in the part of the colon. Without this plexus, normal peristaltic wave formation is impossible. This condition is common in infants with Down syndrome and is associated with the development of toxic megacolon. The classic key to the diagnosis is the absence of stools during the first 24 hours of the infant's life, as well as occasional explosive diarrhea and bloating of the abdomen. The diagnosis is made based on rectal biopsy. Non-accidental trauma. In other words, infant physical abuse. Now I am just gonna mention that you should always keep this diagnosis in mind. This topic deserves a separate video. I think we got little diagnosis sorted out. Now let's break down what you will encounter many times more often. Constipation, the classic cause of abdominal pain in patients of all ages. Colic. Those who have children or siblings probably know more about colic than any expert from personal experience. Colic is believed to be caused by stretching of the intestinal wall by gas. Once the natural evacuation of the gas happens, the colic resolves. Acute gastroenteritis. Pain in the abdomen, vomiting and diarrhea. Most often the cause lies in simple gastroenteritis. In such a situation, the main thing is to ensure that the child does not become dehydrated from the excessive fluid loss. The disease itself will pass with time. Now on to the next demographic group. Abdominal pain in a young child, 3 months to 3 years. Older children can, if not complain of abdominal pain themselves, at least localize the pain. Let's start with the deadly diseases. We've already talked about intestinal, volvulus, and testicular torsion, which are also relatively common in preschoolers. So let's move on to pathologies that we haven't discussed yet. Intussusception occurs when one part of the intestine invaginates into another. This can lead to the intestinal obstruction, swelling of the intestinal wall, and eventually intestinal necrosis. The classic findings is complaints of intermittent abdominal pain alternating with asymptomatic intervals. Abdominal ultrasound aids diagnosis. Pathognomonic findings is the target sign, which is a cross-sectional view of the invaginated section of the intestine. Appendicitis occurs not so often in this age group, but still happens. The clinical picture of children is remarkable for the frequent manifestation with nausea and vomiting, rather than the abdominal pain itself. In general, children are less likely to demonstrate classic migration of pain from the center of the abdomen to the Magburner point. There is another difference. While we do not hesitate to order a CT scan for adults to confirm the diagnosis, it is more complicated with children. They are much more sensitive to radiation and have more years ahead of them to develop cancer. For this reason, children are better served with an ultrasound instead of CT scan. Tumors. Specifically, we are talking about Wilms tumor, neuroblastoma, and hepatoblastoma, which often manifests at this age. Wilms tumor, or nephroblastoma, is especially common in children under 5 years of age. In some cases, the tumor is bilateral, meaning it affects both kidneys. Nephroblastoma itself is usually painless, but symptoms of abdominal discomfort may be caused by the tumor compressing surrounding tissues. Neuroblastoma is a tumor that originates in the sympathetic nervous system. Like nephroblastoma, more than 90% of cases are found in children under 5 years of age. A common location for neuroblastoma is in the retroperitoneal space, where their sympathetic nerve plexus are located. Hepatoblastoma, as the name implies, is liver malignancy. It most commonly affects children under 1 year of age. It causes both soft tissue compression symptoms and classic symptoms of liver damage, such as jaundice. In all cases, the likelihood of finding the tumor during simple palpation of the abdomen is high. Nodules that are large enough to cause symptoms can often be easily palpated through thin pediatric abdominal wall. You probably won't get an accurate diagnosis in the emergency room, but an ultrasound of the abdomen is definitely worth doing as soon as you find a dense abdominal mass. Now let's talk about more common causes of abdominal pain in children from 3 months to 3 years. Constipation and acute gastroenteritis remain at the top of our list, but now a third frequent diagnosis joins them. Urinary tract infection, UTI. I put UTIs in the non-lethal category because the problem is usually limited to cystitis and urethritis. Untreated pyelonephritis can kill a patient, but in real practice it usually does not go to such extremes. Interestingly, young children with UTI, unlike adults, usually complain of abdominal pain, vomiting, and diarrhea rather than the classic burning sensation with urination. Another difference is more frequent development of fever in children with UTI compared to adults. The diagnosis is made clinically and based on urinalysis and culture. Unfortunately, children under 3 years of age usually cannot provide clean urine sample and therefore almost always have to be cathed. Pneumonia. Not really an obvious cause for abdominal pain. The fact is that it can be difficult for young children to distinguish between diaphragmatic pleural pain and upper abdominal pain. So if patient describes symptoms of respiratory infection such as cough, rhinitis, and fever, but also complains of upper abdominal pain, pay attention to the characterization of the pain. If the child cries a lot after coughing and cannot take deep breaths, think pleural pain. An abdominal exam, of course, should still be done, but don't let yourself be distracted from your main suspect, pneumonia. A chest X-ray will help confirm the diagnosis. Let's move on to the next age group, children from 3 to 10 years old. The age choice is not accidental. It is after the age of 10 that the physiological differentiation of boys and girls begins, which significantly changes differential diagnosis. Traditionally, let's start with the what will kill them category. We've already talked about appendicitis, which, by the way, is much more likely to be found in older children and adolescents than in preschoolers, testicular torsion, and tumors. All of these diagnoses should be on your radar when examining school children with abdominal pain. Now let's add a couple more to complete the picture. Diabetic ketoacidosis, DKA. Younger school age is the favorite time for manifestation of type 1 diabetes. The most common time of onset is 4 to 7 years, hence the rule of thumb. All children with suspicious abdominal complaints should get fingerstick glucose checked. Hence saying, glucose is a vital sign. Classic picture is gradual development of abdominal pain, nausea, vomiting, and decreased mental status in a previously healthy child. The diagnosis is made based on combination of clinical presentation, blood glucose levels, presence of ketones in the urine, and anion gap metabolic acidosis. Pancreatitis and cholecystitis are quite rare in prepubertal children. If these abnormalities occur, they are usually related to some other conditions, such as connective tissue disorders or familial hypertriglyceridemia. We will discuss pancreatitis and cholecystitis in more details later. Let's move on to common things are common. Constipation, gastroenteritis, and urinary tract infections remain favorites. Pneumonia should also be parts of the diagnosis if the clinical picture is appropriate. In children under 10 years of age, more adult diseases begin to appear, which we will talk about now. Streptococcal pharyngitis. An unobvious diagnosis, but extremely frequent among this age group. Most patients will play by the rules and complain of sore throat, but a significant number of patients will try to confuse you and manifest with abdominal pain. Therefore, try to examine posterior oropharynx in children with abdominal complaint, especially if they are febrile. The diagnosis is clinical and can be confirmed with strep test. Peptic ulcer disease. The association of pelvic ulcer disease with Helicobacter pylori infection is well known. While the infection itself can occur at almost any age, it takes time for the bacteria to do serious damage, and by the age of 10, that might be just enough time. Ulcers are most commonly found in the duodenum or in the distal parts of the stomach. Diagnosis usually involves both breath test and gastroscopy with biopsy. Nephrolithiasis. Stone formation takes time, even among children with congenital metabolic disorders. Of course, nephrolithiasis in children is on average quite rare, but I still decided to include it because of its relatively high prevalence in the southern countries. Classic symptoms such as flank pain radiating to the groin you will find only in 7% of children with kidney stones, compared to 75% complaining of simple abdominal pain. You will hear about blood in the urine from 15% of pediatric patients. Diagnosis in adult is usually based on urinalysis and CT scan. Because of the problems with children's hypersensitivity to radiation, it is best to start with an ultrasound to look for hydronephrosis. If your suspicion for nephrolithiasis remains high after the ultrasound, you can proceed with intravenous pyelography or CT scan. At this point, we can consider our introduction to pediatric abdominal pain complete. After the age of 10, boys and girls go separately. The average age of onset of menstruation is between 11 and 14 years. Let's start with the simpler patients. Abdominal pain in men. The classic most dangerous causes of acute abdominal pain include several pathologies. Less than half of them originate in the abdominal cavity. AAA, abdominal aortic aneurysm. Classically found in older male smokers. By itself, the presence of an aneurysm, although is a problem, should not cause panic. But if the patient has acute symptoms or if you find an aneurysm more than 5 cm in diameter, it is time to become alarmed. Trouble with such aneurysms is that they like to burst and dissect. Complaints range from sudden onset of abdominal pain to pain in the back, groin, side, or even hip. Some patients demonstrate hypertension and fainting, as well as neurological symptoms caused by spinal cord ischemia. It is best to begin the diagnostic process with an abdominal aortic ultrasound, which has a sensitivity of about 90%. Most patients will also undergo CT angiography before going to the OR or ICU. Acute coronary syndrome includes unstable angina and myocardial infarction. Of course, most patients will complain of chest pain rather than abdominal pain. However, up to 30% of patients show an atypical presentation, including abdominal pain. Many emergency medicine physicians make it a rule to obtain an EKG in every patient older than 50 with an upper abdominal pain. Mesenteric ischemia. This is essentially gangrene of the intestine, most often due to occlusion of mesenteric artery. It is a terrifying disease with mortality rate of 60 to 80%. Etiologically, there are three main types of acute mesenteric ischemia: embolic, about half of cases, arterial thrombosis, 30%, and non-occlusive, 20%. If the reason of mesenteric occlusion is thromboembolism, the underlying cause is often atrial fibrillation. Mesenteric artery thrombosis also does not occur in a bare spot. It is usually preceded by decades of severe atherosclerosis. Non-occlusive mesenteric ischemia is classically found in ICU patients with multi-organ failure and is caused by global tissue hyperperfusion, or simply speaking, shock. The panomnemonic sign of mesenteric ischemia is a very severe pain out of proportion to physical exam. That is, the patient is in a lot of pain, but the abdomen seems fine. Significantly increased serum lactate will aid diagnosis. Abdomen and pelvis CT angiography is also helpful. Perforation. The classic story is a middle-aged man with 3 days of acute onset of stabbing epigastric abdominal pain brought to you by EMS unconscious after his wife forced him to call an ambulance. Perforation most often occurs at the site of the ulcer, and ulcers like to form in duodenum and stomach pylorus. Stabbing pain is caused by irritation of the peritoneum by stomach contents. Over time, pain becomes less localized and systemic symptoms appear due to development of peritonitis. If you suspect perforation, a quick way to test the theory is to take an upright abdominal X-ray. If you see free gas under the diaphragm, call the surgeons. Intestinal obstruction. For the purposes of this video, we will only consider complete mechanical obstruction. It can be caused by tumor, volvulus, severe constipation. Any elderly patient with complaints of abdominal pain, constipation, and vomiting should raise a strong suspicion of intestinal obstruction. While abdominal X-rays can be used to diagnose the condition in hospitals with limited resources, if available, it is better to order CT scan of the abdomen and pelvis with IV contrast. Cholecystitis. The 4 F's rule start: female, fat, 40, fertile equals cholecystitis. But this disease is not uncommon among men either. Most often, inflammation of the gallbladder is caused by a blockage of the gallbladder duct by a stone. The mechanism is about the same as in the formation of acne. If there is a gland, but there is no outlet for its secret, then everything proximal to the obstruction begins to inflame and becomes infected. The combination of pain in the right upper quadrant and a positive Murphy sign, this is the inability to take a deep breath when pressing on the gallbladder area, essentially guarantees gallbladder ultrasound. And based on the ultrasound, the diagnosis of cholecystitis is made. We have already discussed appendicitis, strangulated hernia, and testicular torsion before. I will only say that these diseases are more common in young men than in children. Of course, you can go on and on listing the diseases that can kill your patients, but I don't want to get into rare stuff. We have discussed the most frequent and most important pathologies. Now let's talk about the non-fatal, very common causes of acute abdominal pain in adult men. The caveat here is usually not fatal. Irritable bowel syndrome. The most common cause of chronic abdominal pain, but everything starts somewhere and any chronic pain once was acute. Also, many patients will tell you that the symptoms started recently, forgetting to mention that the same symptoms were there yesterday and the day before and the week before and last year too. IBS is caused by... No one really knows what causes it, and you can't make a diagnosis in one visit. Anyway, just know that if you've ruled out all other pathologies, your patient may have IBS. Pancreatitis. Pancreatitis has 7 main causes: alcohol, gallstones, hypertriglyceridemia, and we don't know. Most patients won't die on you. Pancreatitis can sometimes be very painful and can cause serious complications, but the vast majority of patients will recover after a couple of days of fasting and IV fluids. You need to score 2 out of 3 to make a diagnosis: characteristic epigastric abdominal pain with radiation to the back, lipase at least 3 times the normal range, and abdominal CT scan characteristic of pancreatitis. Diverticulitis. 80% of Americans over 65 have diverticular disease, and the other 20% don't know they have diverticular disease. Diverticuli are small hernias of mucosa and submucosa of the colon through weaknesses in the muscular layer. These diverticuli don't usually cause much discomfort. However, sometimes for one reason or another, diverticuli become inflamed and patient develops diverticulitis. The complaints usually include pain in the left lower quadrant, sometimes fever, sometimes blood and stool. The diagnosis is made on the basis of abdominal pelvis CT scan with IV contrast. Shingles. Abdominal pain sometimes means pain of the skin of the abdominal wall. Shingles is a long-term consequence of childhood chickenpox. It usually occurs in older patients and manifests with a vesicular rash of one or more dermatomes. This means that the rash never crosses the midline. In general, before you send a patient for a CT scan, ask them to show you their abdomen. In fact, it's a good idea to ask patients to take their shirt off during any physical exam. Crohn's disease and ulcerative colitis. Severe conditions that often require surgery. You're likely to encounter quite a few patients with these conditions in your practice. They are characterized by exacerbations with which they often come to the emergency room. Your task is to exclude severe complications: abscess formation, intestinal obstruction, perforation, toxic megacolon. This is usually achieved by abdomen and pelvis CT scan with IV contrast. CBC and BMP, inflammatory markers, and in some cases blood cultures will also be needed. Constipation and gastroenteritis continue to be our best friends at any age. We already talked about nephrolithiasis, but I just want to remind you that adults can easily undergo abdomen and pelvis CT scan without contrast for diagnosis instead of the less sensitive ultrasound. This concludes our brief introduction to male abdominal pain, and we move on to our last demographic group, women. Abdominal pain in women who are not obviously pregnant. Naturally, all causes of abdominal pain in men are applicable to women as well, with the exception of testicular torsion. But in addition to the aforementioned conditions, you will always need to consider abnormalities specific to female anatomy. The problems of women who are definitely pregnant I won't look at all in this video, because pregnant women are a different species altogether. So first, I will share with you the most important rule of thumb. Every woman between the ages of 10 and 65 is pregnant until proven otherwise. Second rule. I am not pregnant. I always use contraception. I am a virgin are not proof that your patient is not pregnant. Hence the third rule. Every woman gets a pregnancy test. Now, in good conscience, let's move on to the what will kill them category. Pelvic inflammatory disease and tubo-ovarian abscess. Pelvic inflammatory disease, PID, is inflammation of the internal female reproductive organs, uterus, fallopian tubes, ovaries, as well as surrounding tissues. A tubo-ovarian abscess is extreme degree of the PID. Statistically, only 15% of them are caused by not sexually transmitted infections. In most cases, the causative agents are gonorrhea and chlamydia. Classic scenario: sexually active female 20 to 25 years of age with complaints of lower abdominal pain and fever. If there is a suspicion for STD, pelvic exam is mandatory. Characteristic findings is extreme pain with cervical palpation. Don't get me wrong, palpation of the cervix is an unpleasant procedure for any woman, but if your patient starts screaming and bouncing off the chair when you lightly touch her cervix, this is not normal. Diagnosis should include a pregnancy test, chlamydia and gonorrhea tests, and pelvic ultrasound to see if there is a tubo-ovarian abscess. Ovarian torsion. The sister of testicular torsion. The mechanism is very similar with one nuance. Ovarian torsion often occurs when one of the ovaries increases in size. If one pole of the ovary becomes larger than the other, this can cause torsion, for example, with the formation of an ovarian cyst. The diagnosis is, as with testicular torsion, is based on pelvic ultrasound with Doppler. Ectopic pregnancy, specifically ruptured ectopic pregnancy. More than 90% of all causes are tubal pregnancies, when embryo gets stuck in one of the fallopian tubes. When the embryo reaches certain size, the tube ruptures. Patient experiences lower abdominal pain and sometimes vaginal bleeding. The diagnosis is made on the basis of positive pregnancy test and absence of intrauterine pregnancy on ultrasound. Ovarian cyst rupture. Ovarian cysts are extremely common among young females. Unfortunately, cysts tend to burst and bleed. Not every cyst rupture is life-threatening, but sometimes the degree of blood loss is sufficient to develop hypovolemic shock. It also can get infected. The first step is to rule out an ectopic pregnancy. Next, do pelvic exam and ultrasound. Treatment depends on the degree of blood loss. This concludes my list of live and ovarian-threatening pathologies. Now back from heaven to real clinical practice. Common things are common. Dysmenorrhea. Menstruation itself is painful. Many young females experience more painful periods than others. Despite the pain, this condition is harmless. Mittelschmerz, in German for median pain. Can you guess what kind of pain is in the middle of menstrual cycle? That's right, ovulation. Most women don't feel ovulation, but for some, rupture of the follicle and the egg release is somewhat painful process. Ovarian cyst. Before it ruptures, cysts grow. and by doing so, they squeeze surrounding tissues. The mere presence of a cyst is not a reason for panic. Most cysts go through natural involution. Fibroids, extremely common among middle-aged women. Fibroids in histological language are called leiomyomas, benign formations of smooth muscles of myometrium. Myomas themselves are harmless, but they may cause discomfort in the lower abdomen, especially during menstruation. Endometriosis. This is the presence of endometrium outside the uterine cavity and a favorite pathology in all exams. All those exams questions about lung bleeding every month. In reality, endometriosis is a very common pathology, but the endometrium usually grows not in the lungs, but in the thickness of the myometrium or in the tissues surrounding the uterus. During menstruation, ectopic endometrium bleeds and irritates the surrounding tissues in which it is located. The diagnosis is made clinically and confirmed by elective diagnostic laparoscopy. Sexually transmitted infections. Gonorrhea and chlamydia are all best friends, and I would like to draw your attention to a continuum of pathologies: STD, then pelvic inflammatory disease, and finally tubo-ovarian abscess. Patients will complain of lower abdominal pain and occasionally purulent vaginal discharge. A simple test for gonorrhea and chlamydia will confirm the diagnosis, but generally it can also be done clinically without tests. Don't forget to check HCG. Urinary tract infection. Every woman at least once in her life will experience UTI. It is due to the anatomic proximity of female urethra in anus. Female urethra is much shorter than male urethra, which contributes to easier penetration of bacteria in the bladder. Typical complaints of lower abdominal pain, burning sensation while urinating, and frequent urges to urinate are sufficient for the diagnosis. Urinalysis and culture will help to confirm your suspicion. Miscarriage. Early on, miscarriage is usually not a life-threatening condition. However, miscarriages are usually extremely traumatic for women psychologically. Most miscarriages in the first trimester are associated with fetal chromosomal abnormalities. The process is usually spontaneous and does not require medical intervention. However, your task is to explain to the patient that what happened was not her fault, that there was most likely a developmental abnormality and then it caused the miscarriage, that it could not have been prevented. If this is not the first case, it is worth sending the products of conception for histological examination. Gynecologic malignancies. Technically, cancer will kill your patient, but in fact it will take many months or years, and your job is to suspect cancer but not necessary to diagnose it. Lower abdominal pain and vaginal bleeding in postmenopausal women is a malignancy until proven otherwise. New pain during sex and non-menstrual bleeding in young women should raise the strongest suspicion for cervical cancer. Such patients need pelvic exam and referral to a gynecologist to rule out or confirm the diagnosis. On that note, let's move on to a brief review of the basic diagnostic imaging for patients with acute abdominal pain. So, in the emergency room settings, we usually have X-ray, ultrasound, and a CT scan. An MRI is usually not feasible if patients are acute. Let's start with X-ray. In what situations might we need a quick abdominal X-ray? When a perforation is suspected, of course, to quickly look for gas under the diaphragm. For many pediatric pathologists like necrotizing enterocolitis or intestinal malrotation. Also, if you think the cause of the abdominal pain is pneumonia or lower rib fractures. Constipations and bloating of the abdomen can also be seen on X-rays, although it is not necessary to make the diagnosis. Now let's talk ultrasound. I'm in general a big fan of ultrasound. Bedside ultrasound is important, necessary, and convenient for modern clinical practice. In what situations will it be the most useful? Children. Appendicitis in a child, ultrasound. Intussusception, ultrasound. Pyelonephritis, also ultrasound. Tumors, ultrasound, of course. Anything related to blood flow also requires ultrasound. Testicular and ovarian torsion, strangulated hernia, etc. Ultrasound will also help in searching for any fluid in the abdominal, pleural, or pericardial cavity from ascites to bleeding spleen. All pregnancies and suspected pregnancies and many other gynecological conditions in general. Many diseases of the gallbladder. And of course, the favorite treat of every emergency doctor, the CT scan. You can find practically everything on the CT. The problem with CT is the high cost, radiation, need for a radiologist, and sometimes inaccessibility of the machine. Everything related to inflammatory and malignant processes is a CT scan with IV contrast. Appendicitis, diverticulitis, intra-abdominal abscess, pyelonephritis, suspected malignancies. All vascular pathologies are best explored by CT angiography, aortic dissection, mesenteric ischemia. CT scan without contrast are best for suspected kidney stones. Tip: if you order a CT scan of the abdomen, always get CT of the abdomen and pelvis so you don't chase your patient for a repeat CT scan because the findings was not fully covered by initial scan. This concludes our review. Thank you for your time.